Are you ready to elevate your expertise in pediatric critical care? Welcome to the Pediatric Critical Care Fellowship, a premier one-year online program designed to equip you with advanced knowledge and skills in managing critically ill children. Our aim is to provide you with high-quality educational materials and up-to-date pediatric critical care information delivered by a panel of highly qualified international expertise. Our professional panel ensures that the curriculum is current, evidence-based, and well-structured. This comprehensive fellowship is structured as 3 modules, 16 weeks each, with a total of 96 credit hours of in-depth training, delivered by a world-class faculty of international experts. Our curriculum ensures that you stay at the cutting edge of pediatric critical care. Your journey with us includes weekly lectures, MCQs, interactive case-based discussions, journal clubs, and virtual simulations, featuring the latest evidence-based pediatric critical care knowledge, plus a dedicated mentorship program to guide your learning every step of the way. From mastering mechanical ventilation and sepsis management, to specialized training in mechanical circulatory support and neurological critical care, you will develop essential skills to manage critically ill children in any healthcare setting. Upon completion of the fellowship, you will enhance your credentials, advance your career, and improve your patient's outcome. With access to a cutting-edge smart learning platform, virtual case scenarios, and real-world applications, this fellowship bridges the gap between knowledge and clinical practice. Join a growing community of critical care professionals who have transformed their careers with this fellowship. Don't miss this opportunity.
Hello, everyone, and welcome to our webinar in critical care pediatrics. And today we have very special webinar because we are going to focus on fluid management. And actually, fluid management in children are very hot topics. And when we reviewed this subject, we have found that we need update and consensus how to do a precise volume assessment and also how to treat our patients better to improve their outcome, how much fluid we need to give, what kind of fluid, when we need to start. That's very important topic. We have great moderator, panelists, and speakers today. Dr. Paige Burgess, she is Associate Professor at Western University. She is our moderator from Canada. Dr. Luca Neri is a pediatric critical care physician and emergency medicine physician, specialized in point-of-care ultrasound, and he is going to lead the discussion with Dr. Samah Ismail, who is a pediatric critical care physician in Saudi Arabia. Dr. Heba Al-Gibali is a professor of critical care and also cardiac critical care in Cairo University. Dr. Marty Widge and Dr. Shigan are both from South Africa. They are going to give us very nice dialogue how to manage our children and how to resuscitate our children with IV fluid. And again, this is our 4th Pediatric Critical Care Fellowship webinar. And here is our brief agenda today. I'm going to give you an introduction about the fellowship. Then Dr. Heba Al-Gibali is going to give just few samples, few MCQs from our fellowship material. Then Dr. Samah Ismail is going to give the first talk on volume assessment in critically ill children. Then we will have 5-minute discussion with Dr. Luca Neri. Then the second presentation will be given both by Dr. Marty and Dr. Shigan about fluid challenges. Then Dr. Beach is going to moderate the session. Then I'm going to give the take-home messages. Again, our Pediatric Critical Care Fellowship is wholly online, 1-year fellowship structured as 3 modules, 16 weeks each. It has lectures, journal clubs, MCQs, clinical case scenarios, webinars, and we have diversity in our fellowship board from United States, Canada, South Africa, Saudi Arabia, Egypt, and United Kingdom, and South Africa again. And because we believe that giving one-way directional education will have very low retention rate, we try to improve our fellows' performance and retention rate by making a discussion and dialogue rather than only giving lectures or let them read. So we try also to improve their clinical practice and let them to adopt and to apply the knowledge in their clinical practice to improve their retention rate. So again, this is a real education, not based on one-way education as webinar or seminar, but we have a lot of challenging cases throughout our fellowship with weekly evaluation and assessment, critical thinking, and we are gathering a panel of expertise. And we have a very smart platform. So all of the scientific materials are released in weekly manner in the platform. So you will have username and password. Then you can navigate throughout the whole week doing your tasks and assignments. Then you need to submit all your assignments before the end of each week. All our fellows' activities are monitored in the smart platform, and there will be weekly assessment and quantitative and qualitative evaluation based on our fellows' performance. Here is our module 1 subtopics. We are going to start focusing on different kind of shock, different kind of infectious diseases, from community acquired to healthcare associated infections. Then we'll have a focus on renal and the critical care nephrology, starting from electrolyte imbalance, then AKI and different kind of kidney replacement therapy. In module 2 are going to focus more on specialized topics and organ dysfunction, starting from the respiratory critical care to cardiovascular critical care. Then we'll focus on nutrition and point of care ultrasound. In module 3, which is 16 weeks of education, we are going to dedicate 1 month to neurocritical care and traumatic brain injury, another month for endocrine and metabolic disorders, and another month for oncological and gastrointestinal disorders. And each module is associated with a semi-final exam. And upon completion of the fellowship, our fellows should be expert in the pediatric critical care field, and they are going to graduate to a trainer and a mentor level, and they are going to receive a graduation certificate from the American Association of Continuing Medical Education. Our fellowship starts in a couple weeks, so August 7th, so please be ready. And the graduation ceremony should be next year. So hopefully every one of you will be celebrating the graduation in July 21st, 2026. So it's a very unique program. If you haven't joined yet, please join. And we have a special promo code today, webinar 10, so you can get 10% discount. And this code expired on Friday, July 25th. So if you haven't done yet, please do it. And without further ado, I'm going to start introducing our first speaker, who is Dr. Heba Al-Gibali. She is a professor of pediatric critical care, and she will be giving just samples of our fellowship materials. Briefly, just in 6 minutes, she is going to give us some MCQs. So I'm going to let her to introduce the fellowship materials.
Good afternoon and welcome everybody. I'm Dr. Heba Tallah Fadel Al-Gibali, a professor of pediatric at Cairo University Main Children's Hospital. I have been working for the pediatric critical care medicine for several years. We would like to welcome you to the Pediatric Critical Care Fellowship Program, which is an online one-year training program designed especially to fill the gap between the knowledge and the clinical practice in the field of pediatric critical care medicine. The field of pediatric critical care medicine is an evolving field. Let's have a brief discussion about what are the teaching and learning methods in this unique fellowship. We are going to depend on keynote lectures, online tutorials, case studies, critical appraisal of scientific papers. Here is a brief description of our program goals. We are going to provide an advanced training in the management of critically ill pediatric patients. Expertise is going to be achieved in physiology, pathophysiology, pharmacology. We are going to foster skills in teamwork preparation, communication skills, family-centered care. We are going to prepare our fellows for leadership roles in pediatric critical care and improve the standard of care, clinical practice, and outcomes. Here is a brief title of one of our journal club educational activities. It's about pediatric shock. It's one of the articles published by the American Academy of Pediatrics. It is up to date about pathophysiology, different types, different tools for assessment, and different management approach for the pediatric shock. Here is one of our clinical case scenarios. Can you please pick for us the earliest clinical sign for a shock in a child? He is 1-year-old female infant with diarrhea and vomiting. Initial impression, he was pale, lethargic, of normal work of breathing. On further assessment. To your knowledge, what is the earliest clinical sign of shock in a child? Let's have a choice from the following. Is it hypotension, bradycardia, tachycardia, cyanosis, or hypothermia? We are going to pause for some time to give you a chance to choose between those items. There is a unique difference between pediatric and childhood shock. The first compensatory mechanism in child is increasing heart rate out of proportion to other factors like fever, respiratory distress, or use of beta agonist, and even the presence of tachycardia out of proportion of the fever, for example, is considered to be red flag. Since the cardiac output is heart rate multiplied by stroke volume, any decline in stroke volume is compensated by increasing heart rate. Additionally, peripheral vasoconstriction helps maintain the blood pressure till a later time. The child does not only increase its heart rate, but he also increases his systemic vascular resistance or the vascular tone, which is going to affect the diastolic blood pressure and narrow the difference between systolic and diastolic blood pressure in vasoconstrictive type of shock, leading to narrowed pulse pressure. To compensate for both the decreased oxygen delivery and the acidosis by tissue perfusion and declining tissue perfusion, the respiratory rate increase. That's why it's late sign to have hypotension in a child. The blood pressure eventually falls. This is very late. This is an ominous sign. And our rule as a pediatrician is to treat children before this advanced stage of shock with hypotension is reached. Let's have another example of a baby, 1 year old. He is in respiratory failure, he is in severe distress, not responding to oxygen therapy, and he started to desaturate. When we are looking for the fluid chart balance, we have seen as a cumulative fluid balance. Do you think, to your knowledge, what is the best way to differentiate between whether pneumonia is worsening or he is fluid overloaded? Is it bedside echo to determine the VTI, point of care ultrasound, and check the B-line, chest X-ray, abdominal ultrasound, check hepatic veins, Frusi-Mind stress test, and check for his urinary output. Let's pause for some time to give you a chance to choose between those different options. Ultrasound or focus, not only used for predicting fluid responsiveness, but can help us with other clinical criteria and other signs to pick for volume overload, like pulmonary edema. Fluid overload trigger increased density of the interlobar septa of the lung, creating what's called the B lines, can be identified in subclinical overload. Of note, sonographic detection of pulmonary congestion is more sensitive even than X-ray or to auscultation. I meant by we have to gather other clinical data. We have to look for hepatomegaly, for rails, for the B lines, for the cumulative fluid balance, for the number of boluses against the urine output of the patient. In the next slide, I'm going to show you what's meant by A line and what's meant by the B line. To the left side, we have the A lines. To the right side, we have two B lines. It's with other clinical variables, might help us to determine the fluid overload in patients. And finally, I would like to thank everybody who listened to our lecture.
Thank you so much,
Good afternoon and
Dr.
welcome
Heba,
everybody.
for this nice presentation. And without further ado, I'm going to introduce Dr. Luca Neri, who is an emergency medicine and critical care consultant. And he is very expert in the POCUS, the point of care ultrasound, health informatics, and also international health cooperation and innovation development. He is a co-founder and the past president of WIN Focus. Beyond his expertise in the POCUS, he has directed several innovative educational and research programs in public health when it comes to emergency medicine and critical care medicine. Without further ado, Dr. Luca is going to introduce Dr. Sameh Ismail.
Okay, thank you very much for your introduction and for inviting me to moderate this so interesting session. So now it's my pleasure to introduce Dr. Sameh Ismail. Is a consultant in pediatric cardiac intensive care at the National Guard Hospital in Riyadh since 2003. And over the last 26 years, he gave a great contribution to make his unit a state-of-the-art unit recognized at the international level. He's also very involved in research with more than 45 publications and in education both at undergraduate and postgraduate students. In this framework, he's also served director of the pediatric and neonatal critical care ultrasound section of WIN Focus, that you know is a scientific society promoting point of care ultrasound globally in the critical setting. So I'm now giving to Dr. Sameh the floor. Since I'm supposed to highlight the questions from the audience in the QA section, I already wanted to notify Dr. Sameh that there is a lot of interest about particularly the septic shock, the fluid that can be used, and particularly when the treatment should be shifted from the fluid management to the vasopressor management. So maybe that within your presentation, you want to already focus this interest. Thank you very much. The floor is yours.
Thank you so much, Dr. Luca Neri. It's my pleasure to interact with you again. And thanks for accepting my invitation to this webinar. I'm going to run the lecture now.
Hi, everyone. It's my pleasure to be with you today.
Special thanks to Dr. Amr Husseini and the World Institute of Critical Care and Emergency Medicine for giving me this chance. I'm going to talk about point-of-care ultrasound in volume assessment and fluid therapy in critically ill children. First, I'd like to declare that I have no financial conflicts of interest. But I'm working with WinFocus and SCCM for many, many years to distribute the knowledge of critical care ultrasound all over the world. We start with this scenario, patient coming with hypotensive shock, and we give him the first bolus of fluid. And the question, the patient did not respond to the fluid. What should we do next? Should we give him more fluids? Should we start inotropes or do other actions? The common answer I get for this question is give more fluids. And we find many reasons to give the patient fluids. And actually, guidelines is supporting that. So the guidelines, like this one, 2017, Critical Care Medicine, is supporting giving the patient fluids until we reach 60 ml per kg. And until he improves his perfusion. But there is increasing evidence that excess fluids can be harmful and also associated with increased mortality. Adding to that, there is 5 to 13% of the patients can be presented with cardiogenic shock. And definitely this group of patients, they may arrest during giving fluids. So logic thinking, we should know what we are dealing with before we start giving the fluids. Is it cardiogenic, septic, distributive, or obstructive shock? And in the era of precision medicine, we should not act blindly in such critical ill patients. The point-of-care ultrasound is actually one of the important tools for this to help us in assessing the patient's responsiveness, assessing their volume status, and to even monitor the fluid boluses. One of the studies were comparing the ultrasound parameters like the IVC diameter, IVC collapsibility distensibility index, looking at the end-diastolic volume by echo, and looking at stroke volume variation and also peak pressure variation on the aortic valve, compared to the old data like CVP, pulmonary occlusive pressure, and passive leg raising. And they documented that the point-of-care ultrasound in the experienced hands is much, much more useful. Adding to that, many guidelines now for assessing the patient before even giving the fluid, like the Rush protocol, and this was introduced a long time ago in 2006, and in less than 2 minutes, doing some rapid assessment by ultrasound can give you idea about cause of shock before starting. So while doing Rush protocol, if you discover that the function is like this patient on the left, function is depressed, compare this normal to this is the normal function, definitely you will be more cautious giving this patient fluid. Adding to that, if the patient having severely depressed function like this patient, actually giving fluid to this patient may lead to a catastrophic event. So to assess the hypovolemia, there is many tools. One of them is the echo, and in the echo, one of the parameters to look at the LV end diastolic area, and it will be decreased in hypovolemic patients. And even the systolic area here is almost zero because the walls is kissing, and this is what we call kissing walls. And this occurs in extreme hypovolemia. So the decrease in the LV end diastolic area is one of the parameters to tell us that the heart is empty and the patient needs fluid boluses. Also, while giving the fluids, you can monitor the LV end diastolic area and you can assess the fluid status. So this is after the fluid, first fluid bolus, we started to see improvement in the LV end diastolic area. Then with the second bolus, the LV end diastolic area is improving. And with the third, we don't see much of improvement. This means that we reached the maximum of the Starling curve and maximum stretch, and we should not give any more fluid to this patient. This is an example of one of our patients, and on the left here, the patient is hypovolemic, and we see the decrease in LV end diastolic area. And this is after giving the patient the fluid bolus, the LV end diastolic area improved. And this is the same patient in short axis, the papillary muscle almost touching here, like boxing gloves. And
This is after giving the patient the fluid boluses. Another tool is the lung ultrasound. And as we know, the excess volume can go to the interstitial tissue, and one of the areas is the lung. And the extravascular lung water is important for all of us to assess this patient after giving the fluid boluses. As we know, if the aeration in the lung goes down to 95% because of the congestion, we start to see the B lines. If it decreased to 80%, we'll start to see too many B lines fused together, we call it coalescence, and even the ground glass appearance. If you go down to 10% or less, we'll start to see consolidated lung. This is the example, a patient coming with hypotensive shock. We give the first bolus. This is the baseline, the pleural line, and there's no B lines. Then we give him the first bolus of fluid. We'll start to see some B lines. These are the laser-like lines. Then with the second bolus, we start to see many B lines. And with the third bolus, the B lines are fused together, almost white lung, and we need to stop here. We cannot give any more fluids. Another tool is the IVC respiratory variation. As we know, with the respiration, spontaneous breathing, the IVC will collapse during inspiration and will expand during expiration, and this is normal. And if it's exaggerated, this means that this patient is hypovolemic. And if we measure the difference, we call it collapsibility index. This gives us, by evidence, idea about the filling status. In ventilated patient will be the opposite. So during inspiration, because of positive pressure, this will distend, and expiration will be collapse. Then we call it distensibility index. So by IVC ultrasound, spontaneously breathing patient or ventilated patient, we must differentiate. If he's spontaneously breathing, then we can assess the volume status, CVP, by collapsibility index. If the patient is on mechanical ventilation, then it will be the opposite. Then we'll have, we can assess the fluid responsiveness, and we call it distensibility index because it will distend during the inspiration. How we do it? Very easy, by this probe, curved probe or linear probe. We put it in subcostal area, the marker directed up toward 12 o'clock, and we'll see the IVC going to the right atrium. And we can assess during inspiration here, spontaneously breathing patient. So it is small. And then during expiration, it is distended, and we see the difference. We call it collapsibility index. Also, we can do M-mode, and this is better to measure the minimum and the maximum, and we get the either collapsibility index in spontaneously breathing patient or distensibility index if the patient is ventilated. This is the equation for the collapsibility index or distensibility index: the maximum minus the minimum divided by the maximum multiplied by 100. This will give us what we call collapsibility index in spontaneously breathing patient or distensibility index in ventilated patients. And we can assess the volume status spontaneously breathing patient like that. Normal IVC size, the 50%, with 50% decrease in the size or collapsibility index, then the RA pressure is 0 to 5. If it is dilated IVC and the collapsibility index more than 50, then the CVP is 6 to 10. Less than 50, so it's 10 to 15. No collapse, so it is more than 50. This is example of normal IVC, and we see here the normal collapsibility in normal patient. This is on the left, this is the severely hypovolemic patient, and we see how the IVC is too much collapsing during spontaneous breathing. This patient is definitely the CVP less than 5, so 0 to 5, and this patient is in need for fluid. This patient is distended IVC, no collapse. So if this patient ventilated, definitely this patient will not be a fluid responder. And if this patient is spontaneously breathing, this means that there is a major something, maybe tamponade, maybe severe RV failure, maybe pulmonary embolism. Another important study, they looked at the variation in the IVC diameter as a guide for fluid therapy in ventilated patients. So they checked 39 ventilated patients with septic shock, and they gave them a loading of 8 ml per kg of fluids over 20 minutes. And they checked the cardiac output and the IVC change before and after. Distensibility index before and after, cardiac output before and after the fluid bolus. They found that 16 patients, they call them responders, and these are the patients whose cardiac output increased by 15% after the fluid bolus. In this group, the IVC change was 25 plus or minus 15%, while the non-responders, the change was only 6%. plus or minus 4%. If you look to the graph also, after 12% change in the IVC diameter, they started to be responders. Below 12, there are some patients are non-responders. So they put the cut limit for, to say this patient responders or not, 12% distance stability index, after which we call these patients responders. And the higher the change in the IVC, the more increase in the cardiac output. So now the 12% is the cut limit according to the study, and they showed a positive and negative predictive value of 93 and 92% respectively. Another tool, as we said, the diameter of the IVC, but this is not very accurate like the collaterality and the sensibility index. In this study, they checked 15 hemodialysis patients. They checked the IVC diameter before and after hemodialysis and the body weight before and after hemodialysis. And they found the correlation between the weight, the change in the weight, and the change in the IVC diameter. This patient ventilated. If we look at him, there is no change in the IVC with the respiration. So this patient is not a responder by M-mode. There is no change. So this patient is non-responder to fluid boluses. While this patient spontaneously breathing, the IVC is too much collapsing, more than 50, and this patient has low RA pressure, and he may respond to fluids. Okay. Another tool is looking for hepatic vein flow. This is the hepatic vein joining the IVC. If we put Doppler here, we get what we call hepatic vein flow. They found that this is the systolic wave and diastolic wave. These are the most important two waves in the hepatic venous flow. If we look, the systolic wave is usually bigger than the diastolic wave. And this is the normal. Systolic wave bigger than the diastolic. If the opposite occurs, this means that the RA pressure is high. Also, we can measure what we call systolic filling fraction, which is the systolic divided by the systolic and diastolic. This we call systolic filling fraction. They found that systolic fraction of hepatic vein flow is correlating very well with the central venous pressure. So the higher the number, the lower the central venous pressure. And according to this study, they found that it's correlating even more than the IVC collapsibility index. And they found that the systolic flow fraction less than 55% correlate with the CVP more than 8, and sensitivity and specificity are actually higher than the IVC collapsibility index. If we combine both, like IVC diameter, IVC collapsibility index, and the hepatic venous flow, actually, this will improve the accuracy of the fluid status assessment. So combine all together, actually, this will give you better sensitivity and specificity. Another tool is looking for respiratory variation in the aortic blood flow peak velocity. So we put Doppler in the aortic valve here, and we put Doppler, and this is the pulsed Doppler. Normally, we should not see too much variation with the respiration. If the patient is hypovolemic, we'll see variation more than 12%. And if this variation more than 12% is the peak velocity, this denotes that this patient is hypovolemic. Actually, this is one of the most important tools now to assess the hypovolemia. So looking for the variation in the peak velocity, more than 12% denotes the hypovolemia, and this patient would be a responder to fluid boluses. This is a systematic review, looks at some static variables and dynamic variables, and they looked at 12 studies after filtering all the studies by PubMed, and they found that when they compared with the static variables like central venous pressure, pulmonary arterial pressure, and some also dynamic variables like pulse pressure variation, systolic pressure variation, stroke volume variation, comparing all of these variables with the peak velocity and the aortic valve variation, they found that the respiratory variation of the aortic blood flow peak velocity was the only variable shown to predict fluid responsiveness in children. And the static value did not predict fluid responsiveness. So the static variables failed to predict the fluid responsiveness of this patient. Another study, 2024, saying the same data, and they found the same conclusion, that the peak velocity of the aortic valve variability is one of the best or promising parameters for the fluid responsiveness in ventilated patients. So I will conclude here because of the time. And thank you very much. And I will be ready for any questions. Thank you.
Thank you so much, Dr. Sami, for your excellent presentation. So coming back to the question that I read in the QA section, could you give us just a practical view in for example, in a septic shock? Maybe let's talk about the ventilated little patients, so maybe the evidence are more consistent. In this case, what could be the pattern of clinical and ultrasound signs that you will look for? Because we know that as you showed us, that each of these techniques has their own specificity and sensitivity, let's say, challenges and maybe limits, maybe also in terms of evidence, some is stronger than others. But what could be the result of a pattern, a multi-focus and clinical integrated approach? For example, in the case of septic shock, that is a case of interest in the QA section.
Thank you, Dr. Luca, for this question. My advice, if we have a patient in shock in general, we should do the screening in 2 minutes first, which is the Rush protocol. First, to know what we're dealing with and make sure that it's a really septic shock. The other point that sometimes septic shock patients, their function already depressed. So they come to us with acidosis and the LV function is depressed. So I like to know first what is the condition of the heart, and confirm my diagnosis before starting even the fluid. This will take almost less than 2 minutes. Then if we look for what's the best parameter for assessment of volume status, according to the evidence, the aortic maximum aortic variation of the peak velocity is the most evidence-based medicine tool for the time being. But it is a little bit demanding. It's not the easiest way. So my advice to combine all, and according to the expertise of the person. If you are a beginner and you don't know how to do the pulsed Doppler, at least you can learn the inferior vena cava, how to look for the inferior vena cava and look for the collapsibility index, the sensibility index, and you can decide about the volume status. As we said, in ventilated patients, we look for the sensibility index of more than 12%, then he will be a responder. And this is easy to learn or easy to practice. Another tool to do simple lung ultrasound when you are giving the fluid boluses will help. Simple echo looking for the end-diastolic area is also very useful and is not too much demanding. Then you build your practice. So use whatever you can do in the beginning, and then improve your skills, add more tools, and improve your performance.
Thank you very much, Sami. And I see questions that are just asking you suggestion about how to monitor the effect of what you're doing. Actually, we saw that point-of-care ultrasound is great in terms of predicting the responsiveness. So even more than assessing volume status, that we know it's a very complex issue even for other advanced techniques, but it's about responsiveness. So that's the first step. And what about what is following? How I can reassess how many times, after how much time I should decide whether to give fluid or vasopressor. So if you give us a sense of how to monitor and follow our little patients during the next few hours.
Yeah, I think we do the baseline, and then we start with every bolus. We should do at least one study. So if I give the first bolus, I should look for the inferior vena cava. How is the collapsibility index? What about the aortic peak velocity variation? What about the LV and diastolic area? So with every bolus, I should monitor. If the patient is very critical, I may do it even more frequently in the middle of the bolus, or maybe 2-3 times during the bolus. So it depends on how critical is the patient, how responsive is the patient, then I can do the studies. But at least with every bolus, we should do a rapid screen.
Okay, thank you very much. And a very last focus about education and training. In your experience, what is the learning curve about this technique? I mean, not the very basic one that we know we had experience together throughout the world, how a few hours can really enable people to do a rush protocol, even within a one-day course. But what about the more advanced focus eco application that we are reviewing? What is your experience and suggestion?
What we do in our center, we have a pediatric fellowship, pediatric critical care fellowship, and we integrated the point of care ultrasound in the fellowship. So it is a part of the fellowship. First, the fellow, when he join us, he go to the course, the comprehensive course, and then he start to have logbook, and we start giving him some sort of lectures during the 3 years fellowship with hands-on sessions. So he has, in his curriculum, there is a part for the point of care ultrasound, including hands-on, logbook, and lectures. And they start the fellowship with attending the course, the comprehensive course.
Okay, so that's a great suggestion for all the students, the teachers, and who is organizing university and making policy on education. Just integrate the point of care ultrasound to our initial education and to all the continuous education through all our lives. So thank you so much. I'm giving the floor to the other speakers. Thank you so much.
Thank you so much, Dr. Sama and Dr. Luca, for this very nice BOCUS education. And now I am going to let Dr. Paige Burgess to introduce our next speaker, Dr. Shigan, who is going to have a very nice dialogue how to manage our children who need resuscitation. Is going to have a dialogue with Marty. So Dr. Paige, please.
Thank you very much, Amar. I am very pleased to introduce our next pair of speakers, who's Dr. Marty and Dr. Shagan. So Dr. Marty Wig is a pediatric critical care specialist with a passion for teaching and training. She is from South Africa and currently works in a low-resourced area in KZN. She believes that critically ill children do better when we do and teach the basics very well. She has a special interest in pediatric ventilation and point of care ultrasound, so I'm sure she enjoyed our last speaker's talk very much, as did I. She is also an APLS course director and enjoys teaching skills that can improve outcomes for critically ill children. Dr. Shagan is a pediatric nephrologist and intensivist working in Cape Town, South Africa, affiliated with Stellenbosch University. He is currently actively involved in the pediatric residency training program and serves on the executive committee for the South African Pediatric Association. He is also a board member of both World Kidney Academy and our group, the WICCEM. So with that being said, I will hand over the floor to Dr. Shagan and Dr. Marty. Welcome. Thank you.
Thank you so much, Paige. Good evening, everyone. I'm just not switching my video on because I'm having some video issues, but I'm very grateful that Dr. Sama actually gave us a look at how do you monitor patients with your investigations to assess fluid responsiveness. And Marty and myself are going to give us a more practical approach with a case-based study for resuscitative fluids in children. So just again, I'm Shagan and Marty's going to talk. So our objectives are just to look at understanding fluid resuscitative principles in critically ill children, to apply condition-specific management strategies, and then always monitor and assess fluids. I hope we have some participants from around the world, maybe in lower resource settings, that can see how this is applicable. So case one, Marty, this is going to be for you. We have a 10-month-old infant with known tetralogy of Fallot that is unrepaired and presents with diarrhea, vomiting, reduced intake, irritability, and a cyanotic spell. So our findings are the patient's markedly tachycardic with a rate of 170, blood pressure 70 on 40, SATs are 65% on room air, The cap refill is at 4 seconds with cold peripheries. There is no palpable liver. The patient is dehydrated with a reduced urine outputs. So Marty, we've assessed this patient. There's a hypercyanotic spell. The patient's been triggered by dehydration and hypovolemia, and I'm sure the irritability is making it worse. And we have the risk of worsening and reducing systemic vascular resistance. So I think this is important. So I'm just going to ask you the questions, Martin, and I'm going to hand over to you. So how cautious should we be with tetralogy of Fallot patients and their fluid boluses? What is the physiology of this fluid bolus? And then the theme for our presentation is when, which, and how much. Over to you.
Thank you so much, Shagan, and thank you for this invite. So first of all, I think back about my registrar years looking after patients with tetralogy of Fallot, and I remember how I always thought, you know, these kids absolutely love fluid. You can give as much as you want. It will always make them better. But I think it's so important to understand the physiology of each patient with each condition in order for you to make decisions. It is really important to go pathology-based in when you make decisions about fluids. And with my background interest in specifically fluids, now I am much more cautious in giving fluids. So I want to take you a little bit through the pathophysiology of what is happening to our little patient. So with tetralogy of Fallot, we already have a right to left shunt. Okay, so having fever, diarrhea will drop his systemic vascular resistance. That will cause an increased right to left shunt, that will increase hypoxia, make him more acidotic, increase his CO2 because he's unable to clear CO2 when he's breathing, and this will increase the pulmonary vascular resistance. So if you remember this little TET picture, that is our main problem, is we already have that pulmonary stenosis with increased pulmonary vascular resistance. So what will happen? The right to left shunt will increase, and now our patient becomes more tachypneic, and that will then increase our systemic venous return. Okay, so remember what we try to achieve with the fluid bolus, we try to increase our venous return, our preload. Okay, but that might just increase our right to left shunt. Okay, so the first thing about treating a tetralogy of Fallot is, yes, a cautious fluid bolus in a hypercyanotic spell will increase your preload, and it will help you with your systemic vascular resistance. And that will help you to reduce that right to left shunt and improve the mixing and improve pulmonary blood flow. So thereby also improving your oxygenation, so things that we want. But the goal of treatment is to increase your systemic vascular resistance and decrease pulmonary vascular resistance. If you give multiple rapid fluid boluses, you might just have the opposite effect, where potentially increasing that right ventricular volume, and that will increase the right ventricular pressure, worsening that RV obstruction and the shunt. So fluids alone is not the answer for a spelling TET. Okay, we need to do everything right. So let's go to the what, when, and how much. So at the moment, the flavor of the month is an isotonic balanced crystalloid like Plasmolite or Ringer's, 10 ml per kg over 15 to 30 minutes under monitoring. Keep on reassessing your patient. Maintain that systemic vascular resistance. Avoid excessive fluids. Consider things like phenyl and other ways of increasing your systemic vascular resistance. But remember all the other basics very well. Knee to chest. Give 100% oxygen. So remember, oxygen is our most potent pulmonary vasodilator, and we want to decrease that PVR of our patient. Giving morphine can calm them down, even some ketamine that might not drop the SVR so much. Keep our patient calm, and then we can think about other things. One thing that's really bad for that RV that is so muscular is if those patients are tachycardic. And you will remember in our case, the heart rate is 170. So if we can just calm our patient down and slow down that right ventricle so that it can fill better to pump, we will get more blood across that right ventricular outflow tract into the lungs. Use POCUS and other multimodal hemodynamic monitoring devices to help you assess fluid. And then usually for maintenance fluids, in tetralogy, we use a non-restrictive approach, especially if you have this patient already on full feeds. So that is our first case. And I'm hoping that you're going to post us some questions in the Q&A so that we can answer that a little bit later. But I want to get to our second case that I'm going to pose to Shagan, and I think this is a little bit more of a challenging case. So this is bread and butter for us. A 3-week-old little girl presents to hospital with diarrhea and vomiting for 3 days, a history of being very irritable. On arrival, she's clinically shocked and severely dehydrated. Her past medical history is that she was a good birth weight of 3.5, but she has lost 20% of her birth weight. She is breastfed, but her mom is struggling with milk production. So there is your blood gas, Shagan, on the right-hand side. You assess that this baby is hypernatremic, dehydrated with acute kidney injury. You are quite scared about cerebral edema with that very high sodium of 173. So you're worried about rapid sodium corrections. You're also worried about sepsis. And then just to make everything more complicated, this baby also has a glucose that's very high. So those questions over to you. How cautious? What's the physiology of a fluid bolus, and when, which, and how much?
So I think, Marty, firstly, in our setting, it's sad that this is not an uncommon case for us. And often we do have these children running sodiums of 190 to 200 presenting profoundly shocked. And this can obviously make a lot of us very scared. I think I definitely start shivering when I get these cases. So I think let's start with basic principles. So our blood pressure is a cardiac output and by the product of your systemic vascular resistance, and your systemic vascular resistance is therefore influenced by the radius of your blood vessels. So that is crucial in managing these patients. And then the next part is your cardiac output, which is the product of your heart rate, and then looking at what your preload, your contractility, and your afterload is. So if I focus on this diagram, just looking at some of it, and we'll discuss the physiology before I answer those questions, these patients have significantly reduced preload. Their tachycardia exacerbates this because their end diastolic filling volume is markedly reduced. Their cardiac output decreases, and they're obviously shocked. So importantly, we need to restore their fluid volume. So our guidelines suggest 10 to 20 mils, and often in the intensive care setting, we try to be a bit more conservative, starting smaller and reassessing our patients. But this is a patient I would consider a larger fluid volume to administer because we know we need to restore the intravascular volume status. And if we look at our Starling curve with your images on the left indicated by the green lines, there is greater fluid responsiveness in terms of cardiac output with that fluid volume as opposed to a patient who is more fluid replete. So importantly, I would give a larger volume, maybe starting at 10, maybe up to 20 mils per kilo. I would regularly assess my patient looking at their liver. And what fluids would I use? I would probably use a balanced fluid like Ringer's lactate or Plasma-Lyte B. But then the question comes in with the sodium. How do you balance that? And in our setting, a lot of our units don't have balanced fluids. So 0.9% sodium chloride can definitely be given. But the concern you just have to bear in mind is what your chloride sodium ratio will be. And we can exacerbate that non-anion gap metabolic acidosis. But importantly, we have to get our patient out of shock. And then once they're out of shock, I think that running your maintenance fluid is important because our kids often pour stool and can repeatedly put themselves into these shock-like episodes. So we will run the maintenance fluids. And here I'll consider an isotonic balanced fluid with added dextrose. Children need dextrose. And the big thing I wanted to highlight on this side are two things. One, please do not use pediatric maintenance solution. It is an older solution that can exacerbate iatrogenic hyponatremia. And in this case here, can have devastating consequences, and we never bolus with a glucose-containing fluid. And then I think you're going to ask the important question. This is what I always got asked when I wear my kidney hat. What if my baby is not passing urine? So the kidneys need volume to filter and therefore produce urine. So I will give fluid to a patient until they are replete. If my patient is still significantly dehydrated, those are the patients that will not respond to diuretics. So I'll get them replete, and then I will consider giving them a diuretic challenge to try and convert them to diuresis. So summary, resuscitate with an isotonic fluid. We can start 10 moles. We give it slowly, may need to repeat repeatedly. Once we have them replete, consider our inotropes. slow correction of hyponatremia at less than 0.5 millimoles per hour, especially if you don't know the duration of how long it took to attain that high sodium level. Maintenance and deficit fluids are given slowly and cautiously. It's fine to bring the sodium down slowly as you're preserving this patient's brain. Monitor the sodium, your glucose, your urine output importantly, and regularly check your patient, especially neurologically. So Marty, I think we're going ahead of time. So I'm going to jump to case 3. I'm sure questions are pouring in. I see the red icons. So 6-month-old infant presenting with poor feeding, lethargy, and a decreased urine output. Your findings are a heart rate of 180, blood pressure of 65 and 40, SATs are 93% on room air. Your capillary refill is 4 seconds. And again, this child's very cold. There's mottled skin with reduced tone. There's no hepatomegaly, and your baby weighs 6 kilos. So we think this patient has suspected sepsis and he's compensated with his shock and he's progressing to hypotensive shock. And if you can see the diagram on the right, that is taken from intensive care medicine, our heart rate is the first thing to change and then your blood pressure drops. So how cautious should we be with fluids? What is the physiology of fluid bolus, and when, which, and how much?
Thank you so much, Hagen. So I think what we want to demonstrate here is really these 3 unique cases. So this is the case of a patient with septic shock. So a fluid bolus in pediatric septic shock aims to restore intravascular volume, to increase that preload and enhance stroke volume. You can see it on that Frank-Starling mechanism, ultimately will improve the cardiac output and oxygen delivery to vital organs. But this will temporarily raise the mean arterial pressure, and it will help you with hypoperfusion, but it often just buys you time so that you can get source control, get your antibiotics in, and then if there's just a partial response, it buys you time to get your inotropes and your vasopressor support. Excessive rapid boluses in septic shock can lead to fluid overload, pulmonary edema, and worsening outcomes, especially in a setting without advanced monitoring and without ICU. So previous trials highlighted this poor outcome with excessive aggressive fluid boluses, and currently our best approach is to give a 10 ml per kg fluid bolus and then frequently monitor. I just want to briefly take you through the mechanism of septic shock. We need to remember that with our previous case, we had hypovolemic shock. Yeah, we've got the complex mechanism of septic shock that often involves vasodilatation, even sometimes severe vasoconstriction, third space leaking, cardiogenic shock, DIC that can cause obstructive shock, adrenal suppression, and hypovolemia. And fluids will not address all that in your pathophysiology. I love this thinking about this triad and how giving fluids is really not going to help your vasculopathy and your myocardial failure. And in sepsis, we need to think differently about fluids. This is a fantastic study that was done when you're measuring cardiac indexes and fluid boluses. And I think this is what we've all seen in front of our eyes. We give a fluid bolus and we feel that our patient has responded. But if we review that non-responsive patient in an hour, he's back to square one. His mean blood pressures are down again. His cardiac index is lower again. And this study has found exactly that yes, you get a partial response, but it doesn't long last in our patients. And when you reassess them after an hour, you often found that they are not really fluid responsive, that's sustained. So what do we know about recurrent fluid boluses in pediatric septic shock? We know that it's associated with fluid accumulation, acute kidney injury, poor clinical outcomes if you have that positive fluid balance at 24 to 48 hours. And what does that do to you? It increases your ventilation days, your ICU stay, your mortality, and your increased risk for acute kidney injury. So what is the key points? Multiple fluid boluses is associated with adverse outcomes in pediatric sepsis. Even in the presence of cardiovascular compromise, only 50% of children will improve their cardiovascular status with fluid boluses, and 50% will not. Use your multimodal hemodynamic monitoring, like we spoke about POCUS earlier. It can be massively useful for us. And consider early inotropes in sepsis, especially in the non-responder group. Shagan, I'm going to hand over to you to quickly tie together these 3 cases for us.
Excuse me. So just a quick summary. Use isotonic balanced crystalloids for resuscitation. Keep your volume simple. We start with 10 mils per kilo over 15 to 30 minutes. And again, once the fluid is in, remember, it doesn't come out. So that's why we are cautious. Tailor your fluids to your underlying pathology and reassess frequently. Monitor for under and over resuscitation and early inotropes in fluid refractory shock. I think that's critical. Don't be scared of your inotrope, and we often use them as adjuncts to try and tide our patients over. Marty, thank you so much for helping me do this presentation, and Paige, over to you.
Thank you so much, Shagan and Marty. I think those three cases were so, I think, poignant and just showed the complexity of our different patients that present, and how if we really break it down and consider the pathophysiology that is behind each patient's shock, it can make determining a management plan a lot easier. So thank you very much for your excellent cases and explanations. There are a couple of great questions that I've come across in the Q&A section. One of which was around our patients presenting in shock that are profoundly acidotic. Would like to hear your thoughts on the use of sodium bicarbonate in those patients.
Hey, Shagan, do you want to go for it? Do you want me to answer?
Marty, I know you'd love to answer this one.
Thank you. And so I think the importance is to look again at what is the physiology of why our patient is acidotic. So often you will find with our patients, if we start managing the shock, the acidosis will improve. So often with giving a fluid bolus, your acidosis will improve. Your rehydration that you are going to start will already improve your acidosis. But there's some cases, and especially in our patients with severe hypernatremic gastroenteritis, that's got a chloride-driven acidosis, and we have them on fluids that is like a 5% normal saline to rehydrate them. That can really drive our acidosis in terms of the high chloride intake. So for those patients, sometimes thinking about giving them less chloride and giving them still sodium, but maybe in the form of bicarb, might help them. But routine bicarb in patients like that is not really advised. It's rather advised to make sure you treat the underlying condition, make sure you get them out of shock, and you will find often those patients' acidosis improve markedly afterwards. We sometimes in South Africa use different cocktails, so it depends on who you speak to, but some of us likes a chloride-free cocktail that we make a mixture with about 80 to 100 millimoles per liter of sodium, and we remove chloride from our fluid to try and get that chloride-sodium balance a little bit better. Some will use something like half normal saline and add a little bit of extra bicarb. So although we all know we shouldn't routinely or easily go for the bicarb, we do get cases where, the acidosis is not that easily correctable and there might be a space for it. I don't know if any of our moderators or Shagan wants to add into it, because I think it's something that a lot of people often struggle with and want to consider.
Wonderful. So address the shock first, and if you're struggling, then think about potentially bicarb in special situations. All right. Another great question came regarding the indication for use of albumin or other colloids in patients with septic shock and capillary leak syndrome.
Shagan, your turn.
So I think I'd be very interested to hear what other units are doing, but in our setting, Paige, it's not something that we routinely do. There are very specific indications that we do have for albumin, specifically in patients. Other colloids we don't use, barring if we are going to use stabilized serums, or if we're using actual blood products as our only colloids, we won't use any of the others. In terms of albumin itself, we will use it in patients who have refractory anasarca, for example, in our severe renal patients, who will use it in conjunction with diuretics at the same time, bearing in mind that in critical illness, your albumin is an acute inflammatory marker, and you need that albumin just to bind your drug. But beyond that, we won't use it as in the acute setting. In specific cases, when we have given massive volumes of fluid and we think there might be room for it, we might consider it, but it's not something that we routinely do in our setting. I would be interested to hear what you do in Canada in your institution.
Yeah, I would say my experience is relatively similar. Certainly, it's not our first line therapy, and I always tell my trainees if they'd like to start a fight between two intensivists, all you have to do is talk about albumin. It's a very contentious, highly debated topic. But certainly in my experience, I typically reserve it for those patients that are really quite third spaced, and I'm trying my best to mobilize some fluid out of the extracellular space, pull it back, or the intracellular space, pull it back into the intravascular space. So usually I would use albumin only if I'm chasing it with Lasix, so to speak. And then I know that we're over time, but we have one more question, and that's around how do we choose our vasopressor, or inotrope, I should say.
Okay, I can go for that one. So I think it prefers, I mean, it depends on who the intensivist is, because I think it's like we all have favorites. Where I work in a low resource country, we have noradrenaline, but we really need to motivate for it. So we try to preserve it for our patients that really needs it and goes onto a second line vasopressor. I find adrenaline, is cheap. I really love adrenaline. I think we need a whole session on just how do you choose your inotropes, because I think, again, it's so important to understand different conditions, the physiology. We need to understand the pharmacology of each inotrope to help us decide. Dopamine is falling out of favor in the pediatric population, so I prefer starting on adrenaline. If my patient is very vasodilated and warm shock, I would start on a higher range because I know that would give me that alpha squeeze that I need. If my patient is little bit cold peripherally, I will start on lower doses so that I can get that beta effect and just try and vasodilate them. So I think, again, if you've got a patient with clear warm shock and you don't have resource constraints, then you might go for noradrenaline as a first line. But I think in low resource centers, there's no reason to just jump to noradrenaline. I think adrenaline can do a lot for us. And I also think we need to be careful of just adding in more inotropes. I often see in my morning ward rounds, my patients are on double inotropes. And I find sometimes people haven't optimized one, or they're actually seeing the side effect of the inotrope and trying to treat that with a second inotrope. So I think you really need a separate session just on inotropes so that people can understand what can inotropes do for you, how to monitor, when to add, and which one to go for. I don't know if that answered your question.
Yeah. I think, Prof. Amar, you have the topic for our next webinar is how to choose an inotrope. That's such a massive topic in itself. And what Marty said, I think she answered it adequately. Look at the physiology to know what you're targeting and choose your patient condition and your inotrope appropriately.
Dr. Marty, Dr. Shagan, thank you so much for your excellent cases and explanations with these questions. I'll hand it over to you, Dr. Amar. Oh, I think you're muted, Amar.
I'm very sorry. So thank you so much, Shagan, Beej, and Marty, for this very nice discussion and dialogue. Our next webinar is actually organized by Dr. Beej, and she is going to focus on how to monitor our children, during and after resuscitation. So it would be very important. I think it's scheduled for just in a couple of weeks. It would be on August 6th, Beej, right? And we'll have great speakers as usual.
Yes, we're going to be having two different presentations as we usually do for these webinars. One will be talking about monitoring techniques in lower resourced settings, and then the other will be talking about monitoring techniques in higher resourced settings. So it is bound to be a great session.
Very nice, very nice. Other housekeeping stuff, by tomorrow, all of you should have the recorded webinar on YouTube, so you can watch it and learn more about the point of care ultrasound and volume assessment, and also the field resuscitation. We have two WhatsApp group, one general that we have close to 1,000 member, and we also deliver free education. And we also have a specific private group for our fellows when we teach higher quality in-depth education. And the fellowship is starting in a couple of weeks. So for those who already joined, we will have an orientation meeting in 10 days, and all should get their credentials for the platform with username and password a couple of days before starting the fellowship. So for others, if you haven't joined yet, I think there is several reasons to join. It's very high quality education. It can accommodate your work schedule. If you have any financial issue, you can submit an application to get a scholarship, especially if you are from resource-limited settings, country, and low-income countries. And with that, I really thank everyone for this very informative session, and we'll see you back in a couple weeks.